Hi there, everyone. It's Karen here. I've got the giggles slightly because just before I came live on air, Ben, the lovely guy from Disruptive, who do all of this streaming and media and putting together for us, and are wonderful. He was like, right, this episode has to be 30 minutes because my amazing guest has to go off afterwards. So you've got to cut down on your intro, Karen. And I realised by saying all of that, I'm making my intro longer than ever. Right. Okay. It's series 4, episode 4 of Probably Nothing. It's the last episode of the series. We started about a year ago, no, about 9 months ago, last June, because I run the Ask Eve information service at the Eve Appeal with our amazing gynae nurse, Tracy, who, if you're a fan of the show, you'll have seen me interview several times. And lots of calls and emails that come to us at Ask Eve start with people saying, sorry to bother you, it's probably nothing but, and then they go on to ask their gynae health question. And yes, most of the time it is probably nothing, because it's important to always remember that all of the symptoms of all of the gynae cancers are always much more likely to be something less serious. But as a gynae cancer charity, and the fact that 58 people are diagnosed every day in the UK with a gynae cancer, it's our job to tell you about the gynae cancer side of things. So we started Probably Nothing, a different topic, different expert, different question to dig into each week to kind of try and make the world of gynae cancer, the world of gynae health and vaginas, accessible and informative and easy to understand, and to kind of bust the myths and answer your questions. So this month, March, is Ovarian Cancer Awareness Month. We've had 3 previous episodes of Series 4 about the symptoms, if you're diagnosed with ovarian cancer, what treatment to expect, and about the BRCA gene alteration. Those are the 3 episodes we've had in this series so far. You can go back on all our social media channels or YouTube, YouTube, to catch up on them if you're interested. But we're still stuck in the house after a year, and I thought, you know what? I want to end series 4 on a high with a big bang. Not literally, because that would be the nighttime work. Don't sack me. No, very nice. So we're going to ask a GP your gynae questions. So I've got the amazing Anne Connolly, who I'll introduce in a minute, and I've seen Anne speak at various APPGs and conferences we've both been at, because once you're in the vagina world, you see the same people at everything. It's a very cool club. And Anne specialises in sexual, women's and gynae health, and is going to answer your quick fire questions that I've got here. So we're going to go for it. Hello, Anne.
Hi, thanks for this.
Hello. Can you just give us, when I just get the questions up, a little introduction to yourself and kind of what you're particularly passionate about, and kind of why we're talking?
So thanks. Yeah, thanks for asking me to join you on this. I am a GP, and I've done general practice in the centre of Bradford for more years than I care to admit to. I have a passion about women's health. I have worked in the sexual and reproductive health clinic, providing contraception for many years. I work in the local gynae department. I was doing colposcopy, which is where you go when you have your smear problems. I now also continue to do the abnormal uterine bleeding clinic. So that's where you go if you're having period type problems. I work in a general practice now, which is focusing on asylum seekers and refugees, homeless, sex workers. And my big passion is not only for women's health, but also about inequalities. And women's health is a big inequality issue anyway. And then if you come from one of the more deprived communities, it impacts on that. So yeah, and I love the title, Probably Nothing, because I don't know how many times in my career, and particularly over the COVID times, now we're doing remote consulting, that women don't 100%. Come to us because they go, it's probably nothing. But the point is, if your period problems are affecting you, or you've got something that you don't understand about, it is not probably nothing. It matters to you. And we're seeing more cancers at the moment because women are just putting it off. They're just saying, it's probably nothing, and then it settles down. It is not probably nothing. It needs a discussion. So great. This is brilliant. Well done.
Let's go for it. And I just to go on to that, we get so many people come to us saying, I wanted to email you first because I don't want to bother my GP during the pandemic. And I say, your GP wants to be bothered. They're still working. It just might be, a video chat or phone call first before coming in. you want to be bothered, don't you? You want people to ask you their questions.
Exactly. And we can deal with a lot over the phone. And we will try and deal with it over the phone because we're trying to stop you coming into an area where there's more risk, and we're trying to protect our staff. But if we need to see you, we'll bring you in and we'll make it safe for everybody.
Of course. Thank you, Anne, for starting off with that, because I think that is something lots of people are worrying about. So, okay, so we've got about 25 minutes. So I've got some questions. They are all over the shop in terms of gynae health. So I'm just going to ask you the question. You're going to answer it. It's like a gynae buffet rather than one particular topic. So let's go. It's N series 4 on a high. Okay. Hello, Anne. Can a vagina be too acidic?
The questions you sent me are absolutely fantastic, and all of them are so important. The more issue we have with vaginas, so there's a set pH of the vagina. So, alkaline, acidic, go back to your school days.
The test.
Exactly. As long as it's about the right level, we have bugs in our vagina and they all live happily together. But the trouble is when the pH changes, and actually it's more of a risk when it becomes, not a risk, but it gives more problems when it becomes more alkaline. So then women get an imbalance of these bugs, and the bugs then, some bugs overgrow, and then women will get something called bacterial vaginosis. And then that causes can cause a smelly discharge. It can sometimes be aggravated after sex. It can sometimes then settle down all on its own. But the biggest problem is that the women are worried about the smell, and then they try and do more about personal hygiene, and then that makes the whole thing worse. So basically, the vagina needs leaving be. So don't, douches, products you buy over the counter on the whole.
Scented things like scented herbs, putting up your vagina, leave it alone. It cleans itself.
Exactly. Leave it be, and then it'll be fine.
Is it true, this is a question for me, is it true that semen and menstrual blood are a bit acidic, so can upset the pH balance?
So women will more likely notice the BV around period time and after sex. So that becomes more of a problem. So then they worry about it more because what their partner going to think, etc., etc. So just leave your vagina be. Some of the worst stuff that's happened to our vaginas is some of the stuff you can buy over the counter
that we're doing to ourselves.
Exactly, and then women come back with recurrent BV, bacterial vaginosis, and actually that's the cleaner women. We have to, they say, I feel really dirty, and you go, no, just stop putting too much up there, because actually you're too clean if you want.
Your vagina looks after yourself. Yes.
Exactly.
What are the symptoms of vulval cancer?
Okay, this is a good one again. Vulval cancer is rare, but it's really important, as are all the cancers. So if you've got a recurrent itch that just you can't get on top of it, so you often, women will try moisturizers, they'll even try steroid creams. But if it keeps itching, then and particularly if you notice a cut or an ulcer or something that just, a thickening of the skin, sometimes women will have a look. Lots of women don't like to look. Sometimes their partner will have looked. But if you are worried about the appearances of your vulva, or you've got this recurrent itch that keeps coming back and you cannot get on top of it, or you can get on top of it, but then it comes back, your GP needs to look.
Okay. Can HPV clear after 10 years, or does it get to a point where you're just stuck with it for life?
So HPV, human papillomavirus, there are lots of different strains, but the two you're most interested in are the two that you're most interested in are the two bigger strains, more problematic strains for cervical cancer, but they also cause vaginal cancer, vulval cancer in some. They're the two high risk strains. We've got a lot of other lower risk strains. HPV is a sexually acquired infection. You don't have to be, it's not like, gonorrhea or chlamydia, but you get it by sexual contact. And the issue with it is the persistence of it and the age at which you get it are the higher risk for getting cervical cancer.
Okay.
Now, youngsters are all getting the jab in school these days. So we know that the younger women who are coming through the cervical screening program are now HPV negative. And if you're HPV negative, then you are very, very, very unlikely to get cervical cancer. Not completely, but very unlikely to be. So the jab is absolutely brilliant, and it's demonstrating huge amounts of success. The jab actually also does against a couple of the strains of the virus that give genital warts. So we're seeing genital warts rates drop dramatically as well. But the problem for some women who were born before the immunization program started, they are the women who may have persistent HPV or may get HPV infection later on. And then it is our own immunity that clears it. So some women, it will just stay and cause a problem for life, or they might get infected later. But smoking probably is stopping smoking is probably the single most useful thing you can do to stop yourself and to help your own immunity get rid of HPV.
Being BRCA1 positive, will changing my lifestyle help with my risk? So I presume then in terms of ovarian cancer, what can I do and who can I speak to about it? So if you're BRCA1, if people don't know, we did an episode on this last week with Adam. You're at a significantly increased lifetime risk if you're so I'm female at birth of breast and ovarian cancer, and men can get breast cancer as well, but it's much less likely. So I guess someone wants to know about reducing their risks for we'll go with ovarian because we're gynae. What can someone do? Can they go on the pill? I've heard this.
Yeah, it's a complex discussion, and this is something. So if you've been told you're BRCA1, so you know that, you must at some point have had contact with the genetic service. Yeah. And this is really a individual consultation with your geneticist or whoever it was who did that test. So it might be about going, some of the charities they will give information online about this, but this is a specific individual question, something I can't generalize on. However, particularly for breast cancer, we know we can reduce and ovarian cancer, we can reduce our risk by other lifestyle stuff. So all women can reduce their risk by maintaining a BMI, a good BMI. We know obesity increases estrogen, and that increases some of the estrogen-dependent cancers. Alcohol, smoking, some of those more lifestyle will reduce everyone's risk. And if you're already at BRCA risk, then you've got that added risk to that. But if you're worried, this is a conversation for someone really clever, like a geneticist.
So it's the genetics team the person's been dealing with to talk about the kind of specific ways, because also they said lifestyle, which is what you've covered, but we know that preventative surgery is the kind of true way to reduce your risk, isn't it? If you're BRCA1. But that's obviously not something to be taken lightly. And Adam in last week's episode spoke about that. So for this person, I would say watch last week's episode with Adam. It goes kind of into much more depth about BRCA1. How are polycystic ovaries diagnosed? So let's go with what are they and how are they diagnosed?
Okay, so polycystic ovary syndrome is very common, and it's commoner than we recognise. And basically, the ovaries they contain our egg supply, and the eggs develop in little cysts, and each month we get a few. In normal menstrual cycle, we get a few that develop, and then one becomes dominant, and then that feeds the hormones back to the ovaries and to the pituitary gland, and that triggers egg release. And then in the non-pregnant woman, the hormones will change, and then you will have a period. In polycystic ovary syndrome, women make lots of little cysts, and they sort of get stuck. So instead of one developing and the others degenerating, you just get these stuck at a certain size. So the hormonal feedback sort of gets wrong and confused, and so it reduces the ability to release an egg. And then that means the changes then that would then go on to either pregnancy or to periods don't happen. It's also really confusing because it's linked in with, we call it metabolic syndrome. So that's sort of about diabetes, about the way your body deals with blood sugars. And that's it in sort of how to explain it. There's some very good information on the website, the charity Verity. They've got some good information. And actually NHS Choices does a good information leaflet on polycystic ovary syndrome. So that's what happens. Now, there are different groups of women who have polycystic ovary syndrome. The classic group we will see, certainly we see in Bradford, is really related to the insulin resistance and is aggravated by obesity. Okay. So if you don't burn off your sugars in the same way, you are more likely to gain weight. If you're more likely to gain weight, that aggravate the hormones from the fat tissues feed back into the system and make it work. We also, so estrogen is our happy hormone. We like estrogen. It keeps our bones strong. It keeps our heart clear. In excess, it gives risks, as we've talked about with the cancers, but generally we like it. The other hormone we're not quite so happy about as women is the androgens. So it's testosterone, it's male hormones. And when you have too much estrogen, it means the androgens, which we are making more of also with polycystic ovary syndrome, don't get mopped up. So we have higher levels of androgens too. And that
so is this why, Anne, is this why lots of people that I've spoken to with PCOS will have kind of excess hair, like facial hair, because of the testosterone?
Exactly. And also acne. And some women will have male pattern balding. So, you know, the hair recesses. So, you know, the problems with polycystic ovary syndrome, the immediate ones that women will talk to us about are problems with spots, acne, particularly later onset acne. So all teenagers will get acne because their hormones are settling down. But this is in women who persist or women who present later. And hirsutism, so hair growth, facial hair, male pattern, basically. So that's one they will tell us about. The other one that they will find is because the hormones aren't doing that regular menstrual cycle, they often have longer time between periods. And some women will stop periods altogether. Now, the problems then are longer term. So the risks then are about fertility. Because if you're not releasing an egg, you're not going to get pregnant. So that's one of the risks. And then in the longer term, the risks are about, do you develop diabetes or the cardiovascular problems related to diabetes? And there's also a concern about increased risk of problems with womb cancer. So there's the short-term management, then there's the fertility issues, and then there's the longer-term health prevention. Now, the main driver for most of this is weight gain. So if you can reduce your weight, just like we do when we say to later onset diabetes, if you can reduce your weight, then often the symptoms settle down because that extra estrogen from the fat tissue reduces, and that allows your hormones to behave normally again.
And does it need to be sort of officially diagnosed, or is it kind of obvious to you when someone comes in and explains what's going on, or would you then send them to the gynae department for a scan, or can you sort of with your patients manage it without them going to secondary care?
Yeah, it's a great question. So polycystic ovary syndrome is really primary care work. It shouldn't really even be gynae until you get into fertility and the endometrial cancer. This is what we do. This is core prevention work, like we would do for diabetes, like we would do for cardiovascular disease. So the criteria is 2 of 3. One is infrequent or no periods, as long as you're not pregnant. The second one is signs of having too much androgens, so spots and hair. And the third is whether you've got cysts on your ovaries, but they have to be cysts in a specific pattern around the ovary, not just the big cysts that youngsters will get or where you get when you come off a pill. So, and you only have to have 2 of those. And lots of women will have random scans for other reason, and they will be found to have polycystic appearing ovaries, but they won't have polycystic ovary syndrome. Blood tests, sometimes people do blood tests, but it depends when in the cycle you do the blood tests. Because if you do them on anyone mid-cycle, it will tell you that you've got a polycystic ovary appearing cycle. So it is, for me, I don't usually do scans. I certainly don't do blood tests. I will, unless I'm trying to look at a differential diagnosis. And then I might be looking at things like thyroid problems. So for me, it's primary care. It's a long-term condition because you don't grow out of it. This is something you've got for life, just like you've got for asthma, just like you've got, diabetes risk. And it's a lifetime thing. And it is very frustrating for women because they will often say, I eat less than my neighbor does. I eat less than my sister does. I exercise more, but I'm still putting on weight. And that's the truth of it, but that's
why can't I bet you get this question all the time? Why can't I get a smear test before 25?
Yeah. The problem with and I was around when we were doing smears on younger women. It's slightly different now because of the women who have had HPV jabs. So the women who have had HPV jabs are very unlikely to get problems that require an early smear. So cervical cancer rates are going down. We know that, or high grade cervical changes are going around in that young group. There's great evidence to demonstrate that. But the problem when we used to do smears with the 20-year-olds is you've got a very immature cervix. So the cervical changes look abnormal. So this is before we tested for HPV. So lots of women were getting over-treated, over-investigated, and then over-treated. Whereas if you'd have left them till they were 25, the cervix would have matured, and therefore the treatments wouldn't have been necessary. So routine screening under 25 is more risky than not. And now, particularly with the HPV immunizations coming through, it's really not appropriate. But if you've got bleeding after sex, there might be a reason for that. So if you've got bleeding after sex, it's not probably nothing. This is what's going on with my cervix. I have to say chlamydia is the commonest cause of postcoital bleeding after sex. So if you've got bleeding after sex, then a chlamydia swab is something that you should be advised to do. Chlamydia swabs, very easy. You get your own swab, you put it in your own vagina. In Yorkshire, we say you give it a good mooch around. So, you don't necessarily have to go and have that horrible speculum examination. You do it yourself.
Anne, has anyone ever said a mooch in the cooch?
A mooch in the pooch. No, but I will do now.
Good. So it's something you can easily do yourself. You don't need to go in and have a big examination or.
So right now, at the moment, if you've got bleeding after sex, if you rang me and said I've got bleeding after sex, the first thing I would want to know is about sexual history, And let's be honest, we can't tell in primary care. We can't read your minds. So if it's bleeding after sex, it's bleeding after sex. Tell us it's bleeding after sex. Don't pussyfoot around. It's bleeding after sex. If you've got pain during sex, then tell us you've got pain during sex, because then it allows us to get the right information to make the right decisions about whether you need examining or not. So if you rang me today and said you had that problem, the first thing I would do is do a sexual history, and then I would suggest you popped into the surgery, or let me put one in the post, or lots of places have got them online. So you do that test, and then if the test is negative, then I will bring you in and have a look. If the test is positive, then I would want to treat you for chlamydia or gonorrhea, much rarer gonorrhea, and then see you if it didn't improve. So that's what I would do, particularly younger women.
Yeah, and also, so basically, the main sort of crux of it here, and we say this all the time to people, is if you have symptoms of cervical cancer potentially and you're under 25, you do not need a smear or cervical screening, because that isn't diagnostic. It's screening for hopefully healthy cervix across the country. Woo, off we go.
Exactly.
If you've got problems, you need to speak to your doctor rather than go for a screening.
Exactly, because you're absolutely right, because if it persists, then I would want to see you. And then I would want to examine. And if I think there are abnormal appearances on your cervix, I would not be sending you for a smear test or doing one, because you need to go to colposcopy, where they'll look with the magnifying system and get a much clearer view of what's going on.
What would someone's options be if on an ultrasound they found a 20 centimetre cyst on the ovary?
So 20 centimetre cyst is big.
Yeah.
So smaller
That's
cysts,
big, isn't it? Yeah.
it is. Smaller cysts are common. Every month when you're going through those hormonal changes, we will make cysts, or you will make cysts. And you know, sometimes depending on some of the contraception you will use, you will have cysts, and they are normal. As long as they are small, they are simple. So that means they are just a sac of fluid. They don't have any bits in them. They look normal. It is very normal. And the guidance is, depending on your age, premenopausal, postmenopausal, depends whether you need tests doing or not. But most simple cysts are simple, and they will just disappear because you've had it done at the wrong time of the cycle. The bigger cysts, so the worry is that either they will rupture, and then that's an acute admission to hospital. If it's acute admission to hospital, it's acute surgery. So they will either rupture, or some of the ones that are more solid, they might twist if they're heavy, and they might twist. And then again, that causes an acute problem. And then some of the much more confusing ones, where the appearances are concerning, they will need referral for ovarian cancer screening. 20 centimetre cyst, that needs referral. 5 centimetre cyst in a premenopausal woman, as long as it's a simple cyst, doesn't need anything.
I came off the pill 3 months ago after 6 years on it and haven't had a period yet. Is this normal?
No, most women will return to ovulating very, very quickly as the pill gets out of their system. And it doesn't matter if it's a combined pill or the progesterone-only pill. It gets out of your system very quickly, and that's why we worry about the missed pill rules, because if it gets out of your system, then obviously it's not going to be working for contraception. So you've got to think, is there something else happening? 3 months, probably I wouldn't worry. But, women with low BMI. So if you've got very low BMI, or women who over-exercise, if you're one of those, then that might be the reason. If you've got a higher BMI or a polycystic tendency, then again, that might be the reason. So 3 months, I wouldn't worry. 6 months, I might start. Oh, well, I wouldn't worry, but I might, probably nothing. But I would talk to someone.
Start to investigate after the sort of 6 month mark. Why do GPs prescribe the contraceptive pill without discussing the systemic impact synthetic hormones can have?
Okay. I'm of an age where my mum didn't have access to contraception. So, women didn't have the choices that we've got now. And contraception hormones are taking a whack at the moment, because people are saying, actually, I don't want to take hormones. But you've got to remember that actually they really revolutionized our reproductive sexual relationships, and it gave us a freedom.
Our freedom for sure.
So, hormones, synthetic hormones, it's not ideal, but they're probably better than endless pregnancies or abortions or whatever. So, the other thing about when I'm giving out contraception, I'm trying to get the main messages across, the really important messages. And they reckon we only remember 3 things from a consultation.
Yeah.
So, what do I want you to remember in that consultation? What do you want to remember from that consultation? You want to know when to take it. You want to remember what to do to miss it. You want to think about, STIs. And you want to think about those risks. So blood clot, swollen leg, chest pain, those sort of big things. So we can probably, I could sit there and talk to you for 20 minutes about the side effects of the pill. But how much of it would you seriously remember? So what I do is I signpost people to online resources, so that I'll give you the basic information. Here you are. Sexwise has got some fantastic information. Contraceptive Choices is a brilliant website where you can put in your own information, and it will give you the recommendations, side effects, risks, etc. So if we don't, it's probably because we are trying to make sure you remember the main issues. And actually, please don't forget the benefits of contraception, because it absolutely transformed your life.
Recurrent treatment Okay, so recurring treatment-resistant thrush, is it common? So no treatment's working, she keeps getting thrush.
Yeah.
What do we do?
So firstly, if somebody keeps getting thrush, and it's common, if people keep getting thrush, I've got to think about, have they got any other risk factors? So diabetics are more likely to get thrush. If you're overweight, you're more likely to get thrush. Women who are immunosuppressed for other reasons will more likely to get thrush. People using steroids are more likely to get thrush. So there are some women who are more likely to get thrush. Sometimes, very rarely, but sometimes most thrush is caused, or most of the vaginal itch is caused by Candida albicans, which is a specific strain, but sometimes there are different strains of Candida. So it may be you need other tests doing, it may be you need to go to the sexual health clinic where they've got access to more different types of tests to make sure that it is Candida albicans, which is the one we usually treat with those products. Other things are, if it keeps happening, then it might be that I need to see you because you might have a vulval cancer. You might have, is it eczema? Is it psoriasis? Is it lichen sclerosis? Is it another skin condition that's causing it? So the BASH guidance, so British Association of Sexual Health and HIV, BASHH, yeah, that's right. They've got guidance for us, and people can have a look at it on recurrent thrush. Sex-wise, the charity, have lots of information. So have a look. But if it keeps coming, and it's not responding to treatment, then someone should examine you.
Yeah. And one final question, because we are running out of time. Okay, so I'm in so much pain with endometriosis. What can I do short term? I'm signed off sick, and I'm on 8 times 30 milligrams of codeine a day, and I'm 22. Oh, poor thing. That sounds horrible. So endometriosis, if people don't know, is the tissue that's kind of like womb lining tissue is found outside of the womb. So it can be found on people's ovaries, on their fallopian tubes. It can sometimes kind of seal close to other organs, and that's kind of when it's extreme. But basically, endometriosis is more common than people realize, and it is very painful for some people.
Absolutely, and we often underestimate the impact, the social impact, the psychological impact, the physical impact. Endometriosis UK, brilliant charity, loads of information on there. The point with endometriosis, particularly in younger women, who 22,
yeah,
is that what you want to do to start with is to reduce the bleeding. So try and stop a woman from bleeding to start with. And particularly at the moment, while gynae access and gynae theatres are less available. So taking a hormone back-to-back pill, progesterone-only pill, depot, the injection, having a Mirena the hormonal coil put in, they will reduce the bleeding and reduce the pain in younger women. The problem with all that scarring and all that endometriosis over the years, it causes longer term damage, and therefore it's more chronic pain. So we have to go down the chronic pain route as well. Surgery is probably where you're heading, but in the short term, I would get yourself on the pill, consider having a depot injection, consider using the Mirena while you're waiting for the referral for surgery, where they will do a laparoscopy and burn those bits of endometriosis and hopefully reduce some of the pain. But don't tolerate it, because this is not probably nothing.
That was the most perfect sentence to end on. Don't tolerate it. Don't tolerate it. Even if something isn't gynae cancer, it doesn't mean that you have to put up with it, because it's not the most serious thing ever. If it's affecting you, it is crucially important to your health and your everyday life.
Exactly. But when you go to your GP, because this is something that's really important, keep a diary. So when you come to us, you tell us it. If you've got pain during sex, tell us you've got pain during sex. If you've got, if you've got vomiting with it, tell us you've got vomiting with it. If you've got urine problems, tell us you've got urine problems. On Endometriosis UK, they've got a fantastic menstrual diary with all these added bits to it. Same with premenopausal symptoms, premenstrual symptoms. Don't put up with them. Keep a diary. Come to us with it. Either send it to us electronically or share it with us on the day. But if we can understand the pattern of it, the problem, then it makes it much easier for us to understand what the problem is.
Anne, thank you so much. Go backstage. I'll say goodbye to everyone and I'll see you in a second. Thank you so much, Anne. Thank you.
Thanks a lot.
Thank you. I think everyone watching can see exactly why I wanted to end series 4 with a gynae drop-in quick-fire round of questions with the amazing Anne. Thank you so much to everyone who's watched this episode. We'll put it up on all of our platforms, our website and YouTube, so you can catch up whenever you want if you didn't watch it live. We'll take a little break, but be back later on in the year with series 5. In the meantime, if you've got any questions about any of the gynae cancers, then please always contact us at Ask Eve, nurse@eveappeal.org.uk. That's the Ask Eve information service that I run with Tracy. Thank you again so much for watching. Stay safe.